many of you know Dr. De Hoog. He's from Bruges, Belgium, and Peter and I have been friends for a long time. I see him as not only a highly respected colleague, but a really good friend. And he's one of the leaders in foot and ankle internationally. So he's a known entity. He's incredibly smart about approaching patient care, particularly in athletes, and how to include science in that approach. So I'll share a quick anecdote in one of my early connections to Peter. So he grew up in Bruges, Belgium, and he shared with me that I shared with him my wife is Canadian, and he shared that Bruges, Belgium was liberated at the end of World War II by the Canadian military. And so if any Canadian visits a bar, if I understand this correctly, Peter, if any Canadian visits a bar in his hometown, they drink for free in honor of that. So he has, of course, gone on to achieve incredible things. He went on to do, after doing his residency in Belgium, he trained with Nick Van Dijk in Amsterdam. And then he went on to Doha, Qatar, where he is now the chief of surgery at the Aspetar Hospital and the chief medical officer at that primarily athlete hospital in Doha. They are hosting the World Cup, and he's a crucial part of overseeing that. So he's going to talk to us today about fifth metatarsal fractures in we won't say soccer, in elite football players. So Peter, truly an honor to have you. Thank you so much for taking the time to be with us, and we'll hand it over to you.
Hey Ken, good morning. Greetings from Doha to everybody. Do you hear me? All right.
Loud and clear, my friend.
Excellent. Thanks for the kind introduction. I'm in trouble now because in Bruges, they don't have only an energy crisis now, but they will have a beer crisis soon with everybody going for free now. Anyway, I hope you guys are well. It's early morning for you guys, I can imagine. And I cherish great memories in the Anschluss, where we had that wonderful, actually award-winning type of research done in under your supervision, Ken, and with your amazing team. And what I remember is that we were being slaved at by you and your team. Early morning wake up, jet lag, long evenings, and the coffee didn't work anymore for us, but for some reason you're a force of nature and you didn't even need it. So with that, we will talk about the fifth metatarsal today. You're very welcome at Aspire Zone Aspetar, where we try to integrate not just the sports medical surgery point of view, but also the sports scientific point of view with a big link to rehab. I have no specific disclosures to the content of this talk, but I do need to tell you that we have research agreements, and that with that, we are being supplied boots by Adidas and Nike. So why the fifth metatarsal? It's a long, slender bone on the outside of the foot. And I've enjoyed, by the way, your M&M so much. I've really learned a lot from it. And we actually see a lot of fifth metatarsal on our M&M. So I think that also says that not all science is written in stone there, and that we can all learn from each other. But there's so many bones we can speak of. Why this one? I guess it's because of the football movements that we put this particular bone in the line of fire with, and that loading, these forces that come through the foot are interesting. It can also be quite tricky to manage. We will go today through the different stages, zones, and different areas. And I would like to bring a perspective from surgical, podiatric, player perspective, and research perspective. So if you just look at social media, you see here the guys from the football research group mentioning fifth metatarsal fracture in a Champions League player, at least out for 3 months. You have Neymar from Brazil national team quoting a bit dramatic that what do you want for your birthday is a new metatarsal. Another one, then you have guys like David Beckham, like Wayne Rooney from England, all suffered from it. So it is quite rare in elite football when you look at the data. 1 out of 5 players, 1 out of 5 seasons per player have it, which is rare, but it can be obviously very detrimental to the career, and especially in the lineup of specific tournaments where elite players miss the dance. So to plot out what that might look like is a figure that I adapted from a podiatric PhD friend. And if you look at the horizontal axis, you have the number of incidents represented. And along the vertical axis, you have the severity or the numbers of days lost. And what we plotted out here is the number of that frequently occurring injury, such as hamstrings, but that will put the player out for that amount of days or weeks. If you then look at the ACL tear, it's of course 6 to 9 months. And the fifth metatarsal is somewhere in between. So about 80 days and so on. That gives you a bit of an idea where it sits. Now, if we look at the anatomy as a refresher and talk about the different zones, we can really link the zone to a treatment plan and identify the different fractures there, the bone stress injuries that might happen, and look at ways to modify the factors that we can to minimize, especially the re-injury link. So this is the fifth metatarsal stress fracture, right? We have the base, we have the styloid process, we have the cuboid, we have the fifth metatarsal that butts up against that lateral side of the foot. And these injuries tend to happen around the base and a little more distal. So everything looks so clean on X-ray though, but remember that we don't always have bone in that area, since we have some pretty large attachments. And this is us looking at the plantar aspect of the plantar fascia, a large, dense structure that is made to store and release that energy. And it also has a component that attaches on the lateral side. So we also have some soft tissue attachments like the peroneus brevis coming into the base there, and the longus that tucks underneath that cuboid. And of course, the tertius and the extensor digitorum longus that can reasonably vary in different people as well. And we have the intrinsic muscles. And not to forget, they generate internal forces on the bone that will cause some bending moments to that bone, some torsion, some twisting, and that will tend to pull on the base of the metatarsal from each of its attachments. So in addition to that, you just have to remember it's a dynamic thing. You have the ground reaction forces that come through and that the muscles are reacting to. So we have these external forces from the ground and from the athlete pushing on the surface, and the internal forces going through the foot. Now, you probably all know Messi, the famous Argentinian football player, Barcelona, Paris Saint-Germain. They call him the GOAT, the current best player, maybe even ever having played. And if you watch at his stance leg, when he's whipping that ball in, you can see how he flicks way over that lateral side of his foot. And this is actually a reasonably common movement for the set piece, very talented football players. They seem to whip the ball in and sweep over onto that stance leg. Now, this is why they are so successful, but this is also why they tend to kind of reach the edges of what the bone allows for. And as an introduction for a surgical perspective, actually our research started when Michael Owen, a previous Liverpool and English national team striker, came to our clinic with a third repetitive metatarsal 5 stress fracture. And then you know that there's obviously the intrinsic factors that we can't always change, but there's so many extrinsic factors that we can change. And that was our mission, because where we live, we believe that all under one roof approach can only benefit in making these extrinsic factors better and tailor better to the needs of our athletes, together with the research group that we link up with. So a bit of word on the treatment, the indications, the return to play rate, the performance, some ideas on orthobiologics, and pearls for success. You all know the basal fifth metatarsal fractures. I won't go too deep in that, but the most frequent are the zone 1. Luckily, the less frequent but annoying, obviously, are the Jones ones, 4%, and then the more diaphyseal stress-related fractures are 3%. The avulsions, well, you see the force vectors that generate, and you have to realize that it's not only the extensile ground reaction forces, it's also the pulling of the soft tissue attachments. So the avulsions are very frequent because of that. Then you can treat them conservatively, but when you go for athletes, you might decide to fix them if you have some bone left, or excise the small fragment. And what we don't like to hear most of the time, but what research tells us, is that if you have a less athletic population,
they do heal the Jones fractures without surgery. Most of the time, up to 96%, they heal without refractures. So things to consider. But the moment we look at athletes, there's a clear difference in time to return to sports, and we take an option of surgical treatment with union rates similar to conservative treatment in what we discussed prior. So there we are. You all know what to use. I like to use the 5mm solid screw, high and inside, and that's kind of classic what we all do together. You do have the cerclage. It gives a good dynamic compression tension banding, but unfortunately it has a low resistance to repetitive loading. We like the plates only for comminuted fractures, for direct good reduction. And I don't know what it is with you, but if the plate athletes, they come to our M&Ms a lot because of the symptomatic hardware, or because of the fact that we may have indicated it not for the right patient. And that's why we try to find solutions, as always, based upon clinical need. And we thought, why don't we combine the cerclage with the more soft tissue, strong sutures or tapes that we have nowadays, and combine them with our screw in order to find solutions to bridge that gap on the lateral plantar side and have a better resistance to these bending moments with a less refracture rate. And then you have the stress fractures. You can use screws, plates, tension band, but in the end, it's all about understanding why the stress fracture has occurred. And we should never forget that. And then a bit of data. I'm gonna remove the previous. I can't see this. Yeah. So our group in 2021 with our fellow Ahmed Attia, he published the largest meta-analysis on MT5 fractures in athletes, including a lot of athletes, a lot of studies. 96.9% athletes were able to return to play, and return to play in surgically managed was 98.8 versus 60 and so on. So clearly an advantage in return to play for surgery. Some other numbers to give you an idea. 100% return to play rate in surgically managed metatarsal fractures. You see the numbers in football, in soccer, as we say, and in basketball. And acute stress fractures and refractures had similar return to play rates. A bit more data, mean return to play 9.7 weeks, between 6 and 12 weeks. And the time to return to play in surgically managed was 9 versus 13 weeks in non-operatively managed. So with a few exceptions, the studies with lower or unspecified percentages of elite athletes had a noticeably shorter time to return to play. A bit more data, you can read it yourself, but I'll give you some essence. Early return to play has been associated with refractures. It's always finding that thin line between going with the wow factor of this is going great and making sure there's not that terrible refracture where the whole hula la message becomes a disaster. So it can be influenced by the desire of the athlete, the fact that they have a kind of higher threshold for pain, for the fact that they have to support in their home country a lot of families, villages even, and that they need to push forward and be so-called hard. We always say for the non-elite athlete, we don't let the X-ray or imaging decide, but for the elite we do, because we need fracture union rate before we can go to return to play. But a bit more on that, because we are trying to stress the limits. We can't make bone heal faster, but we can bring the player in a more sport-specific pattern that the moment the bone has healed, that you're already reconditioned, call it. And that's something we can discuss. Obviously, the stakes can be very high, and the players need to have that shared decision-making with risk assessment between medical provider and player. Orthobiologics, primary fracture fixation on the Jones athletes is where it's usually used and routinely used, but we don't really have comparative studies. But we see in our data that that it's actually used a lot in metatarsal 5 fracture, that biologically augmented fixation. And there's a trend in the results toward higher fraction union rates, which is great, but similar return to play and time to return to play. So that's what we know on the data regarding orthobiologics. The bone grafts, we like the Ilia Crest The return to play rate is great if you add them, but as I said, we don't really have comparative studies. So that's just not scientific enough to convince the pure advantages. But we like it, especially in metatarsal 5 stress fractures, where you have these bending moments, and you will have the refractures if you compress it only. You really need to give it space and a bit more plantar support in order to not to have that refracture. And that's where bone marrow aspirate concentrate and bone grafts and any orthobiologic that you feel comfortable with could help with. So the tips for success: check the vitamin D, especially in wintertime. There's so many athletes that suffer from it. More and more focus on the female football as well with the menstrual cycle. Cavovaras and metatarsus adductus need to be considered. Otherwise, you will always end up in a situation of refracture, and it's not that podiatry can cover everything. Education about prodromal signs, hugely underestimated. I'll touch on it in a minute, but most fractures refracture in the first year. You have the stimulators, the orthobiological augmentation, and make sure that you don't have impingement on the cuboid. Is also quite frequent what we see in patients that get referred to us with ongoing pain. The cuboid is something to look into, and in your history taking and your imaging evaluation, you can perfectly identify that. So, but the best thing is to prevent. So let's put it in the right way, and that helps a lot. So let's now concentrate more on the bone stress injuries. Or that continuum and how we manage them, and how that return to play goes. We need to minimize the chances of suffering in this area again. So with regard of that bone stress injury, which is that in the blue zone, a little more distal along the slender bone there, they tend to occur more in young male athletes who have an increase in training load, like the talented player from the B team that is allowed to also play matches with the A team and wants to show off or at least convince the coach. The midfield position is most common, probably because of the high velocity kicking and the passing during football while standing on one leg. And stance leg is most often involved, which is considered the non-dominant leg. There is recent research coming out, especially from Japan, about the use of artificial turf, where the loading is said to be different, and where they see an increase in lateral foot loading on artificial turf compared to the natural turf that we know. So you have this called potential career-ending injury that was instigated by the first big paper on metatarsal fractures, stress fractures in elite athletes for football by Ekstrand and Van Dijk, who called it a potential career-ending injury, and with a high rate of refractures. So a huge thing, as I said, are the prodromal signs. But these are factors we can manage, and they serve as an early warning sign when the players complain about this vague lateral foot pain in the lead up to an actual event, if you like. And in our research, all players had it. So good communication channels with player are key to pick up these signs and to be able to do something about it prior to that disaster striking. Another big thing is the change in technology from boots that are extremely protective and stiff to boots that are super flexible, almost split sole designs, and light in weight with uppers and overall lightweight material. So these boots on the right obviously offer less protection, but improve the feel for the ball and the surface. There are also changes in the playing surface that we have to consider. The studs and boots are able to penetrate into these softer surfaces that will become waterlogged. Nowadays in the stadiums, we have this incredible technology with playing surfaces that even have vacuum systems underneath them. And the playing surfaces are predominantly made out of sand, which can get a little compacted, and having the players talking about it as feeling hard. We can talk about modifying and changing these surfaces, these boots, and even the type of training in early rehab. So these are the factors that we like to look into. And don't forget, remember the ground reaction force. Usually when you're running in a straight line and you will strike on the outside, lateral side of your foot and then roll inwards. This is where it happens. So a lot of force going through that lateral side and a lot of pressure that the screw fixation that you've put in has to put up with. So also remember that it's not all happening in one plane. we have to move into 3 dimensions on this bone. And once it's in contact with the ground first, there's a large pending moment that repeatedly puts pressure onto that base. So how do we even start looking at these forces? A lot of studies went down the route of someone standing on a pressure plate and looking at the static alignment, or testing if you see any calves feet, or your feet with your feet tilt inwards or outwards, depend. So there's, however, very little evidence that this static evaluation is valuable. So we looked at some more dynamic movements on the field from our cohort of international athletes that did surgery and consequent rehab with us, and we were able to follow them closely in that follow-up. So also we were able to bring the players with a matched control body, which was really cool in training to kind of simulate a similar position that allowed us and improved our testing and our observations. So what did we do? We wanted to look at the loading that happens between the foot, the boot, and subsequently the ground. And we made sure that the groundsmen kept the surface at the same hardness and the same surface properties all over the course of the examinations. And we've put a system in where we had inlays, insoles in that system put inside the boot, and then players carried out some requests of training with a backpack, and that backpack had a logger that sent instant tracing information to our laptop. So nowadays it all goes wireless, but at the time we were already happy to do it like that. So this is the setup we had, and we've put everyone in the same football boots, and then we looked at certain movements. And which movements did we look into with the pressure plates in these football shoes? Well, we did 3 movements. The first one was a set piece kick, where the player will lean onto one leg and kick the ball into the top corner, trying to hit the top post. The second one was where we're looking at some running with the ball in play, where the player had to run to a certain cone and with that ball, then pass it to another player and receive the pass back, and then continue a tight curve around the circle. And we would measure the curve running towards and that injured side, and as well as the so-called non-injured side. So it allowed us to have data on both. And then the third one was a classic straight line running with a set speed of 20 kilometers per hour. And we recorded the players as they ran through. So what did we see? These are all players that actually had metatarsal 5 fracture fixation. So you should consider that but they were considered healed and already playing with their team. So we looked at the pressure at each of these 3 mentioned movement types. And to give you a bit of orientation here, the purple is the high pressure. So the first movement type shows high pressure on the lateral side of the foot. The second diagram as well, with additional pressure over the first ray. And in movement type 3, with straight line running, you can see very little pressure over that lateral side, but much more over the MTP side. So this tells us a lot, actually. And we know that bones need loading and stimulus to get that union and that remodeling. But at the same time, we need to keep an eye on the force, or monitor the speed at which they accelerate into or away from these curves. So that actually changed our whole protocol after metatarsal 5 fracture fixation in our athletes, because we didn't immobilize them anymore. We actually, after 3 weeks, put them in the water treadmill. At 4 weeks, we put them in Alter G with progressive loading. At 5 weeks, we let them straight line run. We just avoid the set piece kicking. We avoid the curve running. Why? Because that's where we put the loading on. And meanwhile, we make them already in a sport-specific way ready, that whenever the bone has healed, they're actually ready. So it's all trying to bring data together to make a little difference. And in players like that, 3 weeks can make a huge difference, and the clubs like it as well. But the main thing is obviously always finding that, what we call the sweet spot. And that's not written in stone as well. So we still have a lot of work to do in that regard. But at least we're trying to use the data that we have to kind of support the treatment and the accelerated rehab for our athletes. And some modifications to the boots can possibly protect that area. But remember that there's a high risk of suspicion if you have a young male midfield player reporting a vague lateral foot pain on the non-dominant leg. These are the things that should ring a bell and create an alarm sign, red flag. And just try to look also for specific training and repetitive load modifications. So it's actually simple, history taking. It's always been the base of medicine, and it's the same thing here, but you have to take the time for it to be able to approach these red flags in the best way. So what can we do? What can be done is to look at some of the areas that we can modify, like the boot itself, the insole, the midsole, or the outsole. Can we adjust these elements that go into these football boot models, and that may help us? Let's take a bit more look at the podiatric part of it. Remember that all of these studs or cleats or blades, they sit on an anatomically bony area. So if we have a very large stud right underneath that base metatarsal 5, effectively it will make a very long lever to cause a pending effect onto the 5th metatarsal. And also the length between the studs is of utmost importance. Studs need to penetrate all the way into the stud plate. If they don't, we end up with areas of pressure right over that stud. And pressure is just force under a given area. So it's not ideal. We need to spread that pressure around that area rather than on one point. So getting information about training venue, how hard the pitch is, how much traction there is, how much moisture there is in the surface, any feedback from the players mentioning that the surface feels hard is super important to us. And the ground staff can actually modify them. So red flags are there. We just need to tell the ground staff and work with them, and not work in our isolated area, but really see this as an entity, as a team approach. So we really want more of shorter studs and lots of them to avoid few studs. Otherwise, we end up with areas of high pressure and high lever. And you can see it here. You have the artificial grass outsole, you have the firm ground outsole, you have the soft ground outsole. And it's a bit technical, but it makes such a difference. I'll show you why. You have nowadays all these particular possibilities. You have, of course, you know all the brands. And again, I have no disclosure, but what we've been looking at is at specifically advising players, not only based on their individual foot anatomy or their way of dynamic movement, but also on the stud position, to have preventative measures in place to avoid the classic problems. And if they're working on artificial ground, they have to wear these ones. If the ground is hard, they have to wear that one. If they're soft, that one. So we really work with the companies to make sure that they have different sets of shoes always available, depending on whether they train on specific areas, how the winter time is, how the ground is well treated or hard or wet or whatever. So it's a bit like the slick choice in Formula One, but it's obviously important, and it's still underestimated how important it is. So other scenarios where the studs are far apart, we sometimes add a stud to support it. If you see here in the right hand image of the shoe, that these are players that asked for an extra stud position there just to cover for all these forces. As you can see, you have ground reaction forces, high lever, you have soft tissue forces, you have that force metatarsal bumping into it from a base reaction force. So this is where we need to support that metatarsal 5. And if the shoe doesn't do it, because the aesthetics are more important than the function, then we have to do it. You can see it here. And it's obviously the most important, the line of leverage. Where the boot bends is another concern. Having the split bend where the studs are at the top forefoot and at the end of the hard heel and nothing in between them. I'm very pleased to say that these are designs that are dying out. Thanks to all our research all over the world and players' voices, all major brands now have modified their shoes nowadays. But we also see that sometimes we can add value to it if players still use it with a stiff local inlay with extra carbon fiber support in the area of trouble. And important to remember is the subject-specific prescription. This is a simple imprint of the Belgian national football team players' feet, where you can see the variability and the different shapes. And key is to find the shoe that provide the individually required support. These are players that play at the highest level, and the variability is huge. So we can't standardize everything, but we can add research to every individual player to tailor to their needs. So what about the width of the shoe? If your feet are hanging out of the shoes, then this is an issue because there will be no support between the fifth metatarsal and the ground, and different inlays can help, and getting to know your boots is fairly important. So athletes can partner with shoe brands, obviously, that mirror their feet. And also some athletes modify their shoes for protection and put plates on the outside. In American football, there's people putting on some sort of clamshell devices that I understand well, which is sort of polycropylene shell that curves over the outside of the fifth metatarsal to protect it. But I'm still yet to find any elite football player that is willing to actually wear them. And as you can see here, the football players tend to be creative as well with their boot makers. And there's so many examples we can give. Like here, another stud placed suddenly in that metatarsal 5 supportive position. It's not always necessary. You now have people that get individually tailored boots where there's no rigidity on the medial side to make sure they can still bend, but on the outside you can see the support from a shoe stud point of view as well. So there's many variabilities, whether you put extra stud, whether you put carbon fiber, whether you put it in the insole, and so on. But it's all to find solutions based upon the individual athlete need. And as you can see here, look at the player. You have the outside turf that is artificial, and you have the inside turf that is not artificial. So it's probably important to mention that while there's a continuum of repetitive stress over the area with prodromal signs, as we said, there's also a documented inciting event. We notice that different surfaces on and next to the pitch can cause these injuries as well. So it's important to speak to the groundsman of the stadium and to avoid that surface friction property difference. As you can see here, he comes outside and suddenly he flips through and has a metatarsal 5 fracture. So that inciting event is important also to mention. These are the 8 stadiums where the World Cup will be played. And I think US is with Wales, England, and Iran in qualifiers. So you guys will play in one of these. But what I wanted to say is that with the knowledge on that artificial turf next to the line of the native grass, nowadays in the stadiums, and this is the Al Janoub Stadium in Doha, where one of the stadiums for the World Cup. And you can see now that thanks to the research, we have been able to have 5 meters from the sideline, have the groundsman keeping natural grass. And that's actually our research that made it possible to protect the player in that regard as well. So just to give you an idea that it's not just looking into things, it's really trying to have an impact to protect our players furthermore. This is what Dick Allen said. He explained his dislike for ArthroTurf. If a horse won't eat it, I don't want to play on it. But yeah, that's kind of as an extra feature, call it. Regarding the foot inlays inside the boot, this is done in our podiatric department. We try to find what fits for the player in terms of comfort, and we use dual densities. So with the back firmer than the front and what is required for the individual athlete. Now, in the normal population, with the flat feet, you would stiffen up on the medial arch. Our athletes, for these conditions that we discuss, we do just the opposite in the athletic boot. A last word. There's some evidence for foot strengthening as well. There's a Japanese study where they saw in fifth metatarsals that these patients tend to have a lower foot strength. So therefore, the intrinsic muscles come into play to bear some of the extra load, and strength endurance could probably be something that we need to look at or into more in detail than we thought in the past. So it's important to communicate with the player what fits best and always try to improve. So with that, the last word is on the female football now, where we had the chance through a kind of a big grant and on a mission with the research done that we need to provide a female football shoe, because we've seen all the variables individually. And nowadays we know that the female have wider forefoot relative to foot length, have a more proximal fifth metatarsal and different ankle shapes and ankle circumference. So with that, we've actually now, with our group, tested all the female Champions League elite European teams. And we hope with that data to provide a bit more detail and offering information in order for the football boot makers to create the female football boot in the best but also protective way. So it's actually fantastic that they for the first time listened to the medical side and immediately incorporate that knowledge into their new commercial lines that they will provide to the emerging market of female football. So in conclusion, look at the prodromal signs and modify the load on the alarm flags. Use turf or artificial ground shoes for non-skill-based sessions to decrease the pressure. After screw fixation, return to play is between 8 to 12 months, even before radiological union, although in elite athlete that's debatable. Shoe width should be subjective to be specific and should be tailoring to bending stiffness of the outsole. Good toe flex strength and endurance are probably more important than we think nowadays, and avoid that large distance between studs on the heel and studs on the lateral forefoot. Thanks for the chance to join you guys. I've learned a lot. I tuned in a half an hour before, and I look forward to discussing anything related about this talk as well. This is our surgical team. We work with 7 surgeons permanently, 22 visitors, and you're very welcome at Aspitar. We actually look forward to host you in a couple of weeks, also linked to the World Cup that you guys will host in 4 years' time, and we hope to join you there then as well. Thank you very much. The last word I forgot is I'm very proud to say that thanks to the huge work of Dr. Hunt and his team, we were able, together with Jeremy, to finalize now the ligamentous injury book on foot and ankle, which we're all very proud of, and we hope that this can be the instigator of much more collaborative work in the future. And I invite you to the surgical skills course in January, and now in October on the football symposium on science and medicine in football. With that, back to you, Denver.
Peter, that was fantastic. Thank you so much. That was probably the best talk on fifth metatarsal fractures I've seen. You covered a lot of ground, so thank you. I want to open it up now to the group for questions. I've got a bunch, but I want to defer here to the group. Questions for Dr. Doog.
Peter, hoe gaan het met jij? Yeah.
Hi, Mark. How are you?
Yeah, very well. So, Peter, one of the issues that I think is important, and you didn't focus on too much, and that is the genu varum and tibia vera that is so common in football players. And perhaps you are addressing this biomechanically, but it comes up particularly with recurrent fractures, where I often wondered, what can we do biomechanically? You know, when the heel is in varus, you sometimes have to consider a calcaneal osteotomy, but how do you approach the mechanical issues with alignment?
Yes, that's obviously the biggest concern, Mark. Our approach to that is rather simple. Look, these players have become the player as they are with the feet that they have or the alignment that they have. So it's a sort of survival of the fittest anyway. Now, if they have a first fracture, we would not address that for the simple reason that we give them their chance. However, if it would be a refracture, then the discourse of realignments come into place in our practice. But you can have a very different approach to that depending on how your philosophy is in that regard. But in a way, our players try to have these few years of elite play, and if that means that afterwards they have to do something more specific related to, for example, cartilage related issues due to alignment or so, we would follow them in that. So we're not just looking at the perfect foot or the perfect imaging, we're looking at the most functional foot that in a risk assessment can deteriorate again. And that's the individual approach you have with the player, the agent, and so on. But it's basically a lot of information that you give, and then you decide yourself. That's how we do it.
Okay.
And what's interesting is, we always think of Kevaveris as the culprit, but Marty O'Malley's NBA paper where he described a 30% refracture rate, it was really the metatarsus adductus. It was more the adductus than it was the the hindfoot or cavus. That's a harder thing to correct, I think, and perhaps accommodate for. But yeah, Josh, I think you had a question. I saw you unmute.
Yeah, I agree, Ken. Great talk. Learned a lot and very well done. One of the thoughts that we've had in looking at these injuries is that I think a while back we kept bone graft for revision cases only if there was a refracture. But then we saw that so many of them healed with iliac crest bone graft that at least my threshold, and I think Ken's has as well, has lowered tremendously where for patients for thinking about primary bone grafting. So I'm curious what your thought is on these when you bone graft, and if you are bone grafting more of them initially at the primary surgery.
Yeah, thanks for that question. I agree. There's actually a paper from my previous mentor, Nebo Popovic, a previous gold medal handball champion, Munich 72, that became an orthopedic surgeon, and that wrote that in 1970 already. Now, in our institute nowadays, with what we know, every stress fracture over metatarsal 5 gets an immediate bone graft, iliac crest. Why iliac crest? Because we have that intrinsic stability cortex that we need, because we don't want to compress the fracture. We just want to give these bending moments a bit more stretch. And by putting that pyramid inside, it really helps us a lot. And then why did we add that cerclage fiber tape to it? Is to keep that bone graft in place. So the so-called cerclage, you just have to aim the tunnels of your more distal cerclage fixation more from the dorsal lateral side to the medial plantar side, so that you can really hold that plantarolateral opening with your bone graft better, and that it stays in place. So we compress it a bit with the screw, yes, but we kind of want to allow the bending moments more by putting that pyramid bone graft in, and we do it for every case that is a stress fracture now, so we don't wait for the refracture anymore.
Peter, what suture material do you use for the cerclage?
Suture tape.
Okay, it's a novel concept, but it makes sense. So do you have,
well, if I can add to that, Ken, the cerclage is very, very badly received in our population. They all feel pain from it, even if you hide it well. Maybe we don't do it correct, but we went away from that, because the last thing we want is a second procedure if we can avoid one, especially in these players. Yeah. So that's why we tried, and we looked at the pull-out strength, and we thought it was okay. And then with a small device we can actually load it a bit and put tension on it.
Yeah, and I'm with you that, and with Josh, that I'm more likely to use autograft acutely, as you mentioned you did in every player, because of the reasons you mentioned. So I'm curious, I agree with you conceptually that the fracture is sort of a way for the body to correct the load. And so you don't necessarily want to compress it and put it right back to where it was, particularly with an intramedullary screw that's not necessarily going to preferentially compress the tension side of the bone where the problem is. So do you then use, I noticed the case you showed was a partially threaded screw. Is there a role for a fully threaded screw if the goal is to not compress and then just really pack in the fracture defect with autograft bone?
I would say absolutely yes. I just can't prove it yet. I did no comparative studies on it. I don't know if there is out there. Probably there is, but I'm not familiar with the recent literature on that, so I don't know.
And Peter, with an acute fracture, first time, fifth metatarsal fracture, no crazy alignment, what are you telling them for return to sport? So when you're sitting with the player, their agent, their coach, when do you tell them that they're going to be on the pitch, and when do you tell them that they're going to be most likely be unrestricted in a match?
Well, with what we do now, we, as always, we say what we know, and luckily the knowledge within the non-medical groups of players is that this is a bad injury. This can refracture. They know that. So that's the beauty of it. They're a bit cautious on it. And then every time you win, while already putting them in some, as I showed, straight set running or Alter G accelerated rehab or hydro, we dare to say that it takes for them 2.5 months to return to group training and 3 months to play. And most of the time, we are earlier nowadays. Yeah.
And there is upside to giving them that expectation, and then you're the hero and they're back at 10 weeks.
I wouldn't say that, because we give ourselves a bit of stretch, and biology is a crazy thing. So if we say 3 months to play, most of the time we get there. And obviously if it's earlier, we're all happy. Yeah.
And I think that, our literature, the American literature, supports that, because as you look through those papers, as Ahmed did, the refractures seem to be in those, you put them back too early group. It's the earlier return that seems to be more likely to re-break. So there's a lot to what you're saying. Other questions or comments from the group?
Hi, Doc. This is Teresa Alpert, the orthotist on the team. Fabulous presentation. I just want a couple of comments. In my experience, my soccer players all love to wear shoes that are too small. So getting them to upsize or even go up a width sometimes can be challenging. And we do use the clamshells here. And Dr. Hunt could probably talk to this even better. A lot of the students, actually, I do a direct heat mold so that it's very, very intimate up to the foot. And then I make sure that the shoe goes over that. So it's very thin to give them that lateral protection, in addition to giving them the arch alignment and the hindfoot alignment. So if you want to talk about that a little bit more, I'm available to do that as well. Thank you for your presentation.
Thank you, Teresa. And you're invited already. We need to learn how you do it.
Other questions?
In the end, Ken, it's all about understanding what's really going on there, and doing the right things to avoid new problems. Yeah.
Totally agree. So to that end, you showed a slide where you had some dynamic pressure insole, maps. Can you comment on what system do you use? We've really, we have a gait lab, which has really state-of-the-art pressure and force insoles. We're installing an instrumented treadmill. What we don't have is like a dynamic insole, like a wireless insole that we can put into a shoe that is predictable. What do you use for that on-field pressure assessment?
Yes, thanks. And it's actually our biomed guys who did that and calibrated it every time. So we didn't really go commercial on that regard because it didn't really exist. So we made it ourselves. Yeah.
So you just got pressure, like just built a pressure insole basically.
Yes, and then linked it to a tracking device and get it into the laptop through the backpack where it lodges in.
We may have to have your biomed guy out to our shop to figure that out, because it's something we're constantly in search of.
But
well, now that the technology is improved, there are a lot of in-sensor soles that capture that kind of information. And there are also shoes that are made with sensors in them, Doc, to extrapolate that kind of pressure and torque as they lift off. HX Innovations is a great company to talk about that with. Also, the F-Scan and Tech Scans, the cellophane insoles, you've seen those also. So we may not need to reinvent the wheel, but we'd love some recommendations.
Yeah, what we like is that team approach brings new ideas. You have the biomed guys involved, you have the podiatrists involved, you have the surgical input, and then suddenly you get data that you say, wow, we can really do something with that in order to have accelerated rehab and still have a good result. And in the end, that's the team approach, and we can all learn from that.
Mm-hmm. The other thing that we haven't talked about is do you test your athletes for vitamin D and K and make sure that their bone quality is optimized?
Yeah, so we test our athletes, all our registered athletes come through us. We have what we call a national sports medicine program, and we have every 6 months a screening for them. So yes, we do. Yeah.
Great. Thank you so much.
Well, Peter, listen, I can't thank you enough, man. That was incredible. Great discussion. I learned a lot. And we are very, very grateful that you joined us.
The honor was mine, and I hope for much more in the future. And I salute you from sunny Doha, and welcome you very soon all here.
I appreciate that. Now go enjoy a pint this evening.
Will do.
All right, my friend. Have a good day,
Bye.
everybody.